have you here. So the goal of this panel discussion is it's a little educational session. We are not going to be debating about any molecular aspect of any particular cancer. It's about, in general, basic questions which you all have, but you probably don't know or scared to ask. So I'm going to be asking those questions to our panel of experts and try to get some answers. That way we can all get educated and raise our awareness about what is cancer and what do we need to do to diagnose cancer at a very early stage and all the treatment options and also survivorship and support group as well. Who is the head of radiation oncology. Dr. Sandeep, what is cancer?
Look, cancer is like a rapid proliferation of the cells, which there is some defect in the genome of the cell. And the basic characteristics of the cancer cells are like they're rapidly dividing. They have a tendency to spread through either the lymph or the blood to deposit in the other organs that will be called as a metastasis. So that makes the whole group of the disease, which is cancer, challenging.
So basically any cell in the body can turn into a cancer. It divides very fast and it's a non-functional cell, it's a dysfunctional cell. It has the potential to invade, spread and kill a person. That's why we dread this deadly disease called cancer. Who should be worried about cancer, Dr. Suchitra? Who should be worried in general? Old people, young people, newborn?
Usually, most of the cancers come in the postmenopausal age group of people, I mean particularly in women. And screening better should start at an early age than that of around 30 years it starts is better. But most of the times it's in the later age group of the patients it's seen.
Mm-hmm. So the incidence of cancer is seen more in elderly people, but it doesn't mean that newborns can't get cancer. Right, Dr. Sunil? Even, right?
Yeah, so any age, no age is immune from cancer, so we all need to be aware of that. Although yes, the incidence is a little lesser in the pediatric and the adolescent age group, but it's still in West the second common cause of death in children less than 15. So it's not as uncommon as either.
So basically anybody can get cancer. The older you are, the risk increases, but based on lifestyle, genetics and those kind of things, anybody can get cancer. So everybody should be aware about the warning signs of cancer and other things that we're going to be discussing. So Dr. Sharath, next question is for you. When we hear the word blood cancer, you know, in movies as growing up kids, we see like when somebody has blood cancer, they cough up blood and a white kerchief, you know, and then we see the blood and then there's a blood cancer. How dreadful is this disease?
So we've come a long way since then. And I think even the other day in one of the interviews, I was telling people that, you know, about 25, 30 years back, if you had 10, 20% cure rates in blood cancer, that was a huge thing. But that's significantly changed to even 60, 70, 80%. And like Sunil has mentioned, in children, it's even higher. And that's a dramatic change over the last 20, 25 years as far as cure rates in blood cancer go. It's definitely not 90, 100%, but still it's a significant, you know, improvement because of newer molecules, newer treatment methodologies, and a lot of changes in the treatment protocols. And that's a very promising, you know, sign of things to come across the board. So something which was equated to a death sentence, now you're talking about cure rates, long-time survivors, and even children going on to, you know, become adults and have their own families. So that's a huge progress in the area of blood-related cancer.
That's excellent news. But still, when you look at the numbers, the 5-year survival rate, say for non-Hodgkin's lymphoma, maybe in the 70s in the Western world, maybe in US, but still it is like probably half of it in developing nations. I'm talking about the population-based studies. Why is that disparity in developing nations about the 5-year survival rate in hematological malignancies and maybe in solid tumors too? What do you think is the factor?
So I think, you know, there are 2-3 issues here. One is we still have this little, you know, delay in diagnosis, which is still, you know, occurring. It is better than what it was, say, 10 years back. But even now, you do have a lot of people who present with stage 4 lymphoma. It's not something which is uncommon. And there you know that you will not be hitting cure rates of 80, 90%. You'll be still in the 50, 60% range. Earlier on, when somebody relapsed, even with the lymphoma, you kind of most of the time just said palliative care. You didn't have the concept of salvage chemotherapy, autologous transplants, or even up to allogenic transplants, which was not the norm earlier. And that has all significantly changed in the last 10 years. In India itself, if you look, you know, about close to about 10, 15 years back, when I just finished my training, we had 5 transplant centers in the country. As of today, there are 50 reporting to the Indian registry. So So that's a huge jump across the board. So obviously this will translate into better survival and cure rates.
Okay. So the key is awareness. Okay. You should raise the awareness. The more you know about your condition, the more you know about early screening and diagnosis, the greater chances of survival. The next question is for Dr. Moni. Dr. Moni, as we know, your practice in US and me too, the number one killer in US is lung cancer, both men and women, right? That's both are equal in US, men and women. So in India, head and neck cancer is the number one killer. Why is that?
So head and neck cancer, I think, it is a cancer caused by bad habits. Almost 60% of the mouth cancer and throat cancer is caused by tobacco and alcohol abuse. But there are people who develop cancer without any causes. So that is a subset. But majority of the cancer is caused by bad habits. Now, olden days it was chewing tobacco and everything. Nowadays, people can chew gutka. They can put in the pocket almost like a chewing gum they eat. Even kids start to eat that. And that is one of the reasons they develop cancers.
So the take-home message is lifestyle risk factors. Like tobacco in any form is injurious to health. Alcohol is injurious to health. We'll come to that. So lifestyle plays a significant role. If you follow a proper lifestyle, you can reduce the risk of developing cancer by 30%. So that's the message that we would like to give. So next question is for Dr. Anthony Pius. Dr. Anthony Pius, what are some of the risk factors for breast cancer?
Being a lady itself is a risk factor. You have many other known risk factors like obesity, massive body mass index, where every kilogram of extra fat produces so much more estrogen, and estrogen, is the cause of cancer. Early menarche and late menopause. So it is a period of total exposure to hormones. So the earlier you have your period, first period, and the later you have your first period, and earlier you have your menopause, the better it is. Unfortunately, in India, we celebrate the day a lady gets her first period. Instead, we should have been actually mourning. The other factors are genetic, but genetic is only 10%. Most people think that is running in their genes, which is not true at all. It's only 10% of these cancers are genetic. You have other factors like radiation, chemicals today, pollutants. All this can cause, can add to your risk factor. Hormones like HRT, too much of it can also cause the same problem.
So can men get breast cancer?
Yes, 2% of all breast cancers occur in men.
Okay. Is there a particular reason, like who is at risk for breast cancer?
Most of them are because of genetic reasons. They may be carrying BRCA1 and 2 gene.
Okay. So, Dr. Suchitra, what are some of the risk factors for gynecological malignancy? May it be cervical cancer, ovarian cancer, uterine cancer. What are the risk factors that put a female at risk for these cancers?
Cervical cancer, it's a sexually transmitted disease, HPV viruses which causes the cancer, and as multiple sexual partners, this turns out to multiple sexual partners, early age of marriage, and all those things will lead to cervical cancer. When you come to the endometrial cancer, it is almost like a breast cancer, wherein high estrogen content in the body, where obesity is more. High estrogen content in the body will produce endometrial cancer, and ovaries, incessant ovulation, what we call it. Like if she's not becoming pregnant or something, or she's nulliparous lady, then the chances of she getting an ovarian cancer are more.
Using fertility medication, does it increase the risk of ovarian cancer?
There have been trials which have shown that not much. There have been some trials have been conducted, and it has shown that they do not increase the risk as much as it was portrayed. Maybe a slight increase in risk is there, maybe less than 1%, but it's not as high as it is shown.
Using oral contraceptive pills, people are worried about using oral contraceptive pills when it comes to breast cancer, when it comes to people at risk for developing blood clots. But does it have any protective effect in reducing the risk of ovarian cancer?
Yeah, it does. Yes, it definitely does. It stops the incessant ovulation, so it definitely decreases the chances of ovarian cancer, and it has been used as a prophylactic therapy for patients who are having hereditary lineage in their BRCA positive genes. Definitely we give it as a prophylaxis for them. OC pills are prescribed for them.
Okay. And women with polycystic ovarian disease, like up to 10% people can have it, the incidence is 10%. Do they need to be worried about developing any kind of a gynecological malignancy?
Yeah, there is a less than 5% chance of them developing an endometrial cancer. It is again relates to the amount of estrogen content in their body. If the estrogen content is very high, there is a chance that they may have an endometrial cancer.
What can they do to reduce the risk of developing that?
Just break the cycle, support the cycles with these progesterones. That will decrease the chances of them to
losing weight. Would it help?
Yeah, definitely.
Okay. So a lot of risk factors you've heard about breast cancer, gynecological cancers, like excess of estrogen in the body. Obesity is the biggest risk factor, because more obesity means more inflammation and more estrogen in the body, because fat gets converted to estrogen. So that will be a fuel for the fire. So again, this is a lifestyle modifiable risk factor. So the more exercise you do, at least 20 to 30 minutes a day, is very, very important. Sedentary lifestyle is a bad thing. We all know that. The next question is for Dr. Sunil Bhatt. Dr. Sunil Bhatt, how important is family history in getting a cancer, and what are the risk factors for getting pediatric cancers?
Coming to the second question first, see, most of the pediatric cancers, unlike what you all discussed, they are not lifestyle cancers. Children do not smoke, they don't take alcohol, but they still, as I said, it's also a disease, significant disease in children which we encounter. So we really don't know what the cause is. There is maybe in 5% of the patients you will have some hereditary cause to it, like some patients with Down syndrome, Fanconi syndrome, they have a little bit higher risk of developing cancers in childhood, but that's probably less than 5%. In 95% we still don't know what the cause is. A lot of theories are there, but probably it's again going to come down to genetics. There are some cells which develop some genetic change and get crazy and start multiplying, but what has prompted that change, probably we still don't know. So that's about the risk factors in pediatrics. And what was the other question?
What are the, how important is genetic history?
So genetic history is very important, especially as I said, and not only in childhood cancers, even later, there are a lot of hereditary cancer syndromes which can run in families. So it's important to know, what has been the cancer incidence in the family. For example, some a condition like Lifferty syndrome, you can have breast cancers, bone tumors, leukemias running in the families. So it's important to know because that will help us in few things. That will help us in, one is counseling that family, and some of them, like in retinoblastoma gene we have in children who develop retinoblastoma, that may help us in genetic counseling for the future pregnancies. That will also help us in early screening of those kids or those patients who are at risk. And also sometimes, I think that's what the future is going to be, is that it may also reflect in targeted therapies, if you're able to identify something, and target that. So that's why it's important to know genetic.
Excellent. There are so many parents here with cancer or without cancer. They're worried, like, what is that warning sign that they need to be looking out for in their kids?
As I said, still cancer, probably in the more than 95% of the cases, is still sporadic. So I think we need not to be panicked about it, and that there's one person in the family having cancer, that all the family members are going to have cancer, or something contagious that is going to spread from one to another. So that I would, when people come across with this question, I said the risk of other child having cancer is the same as your neighbor having the cancer. So it's very sporadic, but as I said, very small percent of the cases which may have some familial cancer predisposition, those need to be identified and then counseled accordingly. But overall, for the public, for the layman, the risk for your child, your brother, your sister, your family member having cancer is the same as any other person in the community.
Excellent. So don't panic, but be cautious. That's the message here. Dr. Sandeep Jain, is cancer curable?
Yeah, the cancer is a group of disease, and depending on the stage, grade, and other factors, what we will find out after biopsy, we will be able to tell what is the percent cure of that particular cancer and in that particular stage.
Can you cure somebody in stage 4 or terminal stage?
Look, we have seen a lot of patients like germ cell tumors where stage 4 cancers can also be curable. The cure rates are very high. So it's all possible. It's not like this, if it is stage 4, it's a death sentence.
Okay. What about in lymphomas, Dr. Sharath? Do you think stage 4 lymphomas can be cured?
Yeah, I think that's, like I mentioned earlier, it's not as high as 80-90%, but definitely we're looking at least about 50-60% cure rates there. And that's one of the good things, you know, which we also want to highlight, that all stage 4 or various types is not the same prognosis. So it depends on the type of malignancy you have, and that's why knowing what your primary diagnosis is and getting the correct diagnosis is very, very important before starting any of these treatments. Because we've had so many occasions where people have been mislabeled as something else and had a mess with their initial treatment, and then you really feel bad because you then lose that chance of curative intent treatment. So I think that's something we should highlight, you know, to push for.
So the message is early diagnosis and treatment, you know, will save cancer, will save a life. So what are the different treatment modalities, Dr. Moni, when it comes to cancer treatment?
Yeah, essentially, cancer is treated by 3 modalities. Being a surgeon, let me put surgery first, but not all the cases are treated by surgery. Now, then comes the radiotherapy, that is giving some radiation to control the disease. Now, to get a systemic effect, whole body effect, you need to give chemotherapy. Now, there is a fourth generation of medicine coming into the scenario called targeted therapy. Now we know the genetic basis, what are the genes which are mutated, and we can target those mutated genes and can reverse the cancer. So a lot of newer things are coming into cancer field. So definitely, as Sharath pointed out, not all the stage 4 or cancer needs to be considered to be incurable. There are multiple modalities of treatment to cure cancer. Now, if we cannot cure cancer, doesn't mean that that's the end of the road. Definitely, we can control almost all the symptoms a patient have by an integrated or multimodality approach. So cancer can be treated, cancer can be cured by multiple modalities.
Excellent. So the message is like, you know, your grandmother would have died like 20 years ago of some lung cancer or something, or grandpa would have died of throat cancer or something. That doesn't mean that if you're diagnosed with the cancer, you're going to die. Things have changed a lot. This is the golden era for oncology. A lot of treatments. We usually, like when we said systemic therapy, we only meant chemotherapy. Chemotherapy is like a shotgun approach. Now we have targeted therapy. We have immune therapy. It's advancing at a phenomenal pace. So one should seek the expert opinion and not generalize every cancer. So that's the message here. So next question is for Dr. Divakar. Dr. Divakar, like, you know, once somebody gets diagnosed with cancer, they're worried. You know, they're always like, you know, what's going to happen to me? They're going to have probably a 5-minute or a 10-minute consultation with the doctor, and then most of the time, you know, the diagnosis is not revealed in some. The family knows the diagnosis. In some cases, the diagnosis is, you know, revealed in a very awkward manner. And the patient goes through a lot of psychological distress. So how important is handling the psychological distress, evaluating and handling the psychological distress important in cancer patients as opposed to just the physical distress which we are currently addressing in most places?
It's very important. Let's leave cancer just for two seconds aside. I just want all of you to think, there are a lot of people here, mixed group, some cancer patients, relatives, doctors, nurses. If we walk into any hospital for any investigation, we all will be, as human beings, we will be anxious. It is a nerve-wracking experience for me if I want to go and see another doctor and get my blood pressure checked. You can imagine the kind of things which goes through a patient when they're going for a hypertension diagnosis, or if somebody is told that they've got thyroid problem. That itself can cause a lot of changes in their mind, thinking that, oh my God, I've got hypertension now, I've got diabetes now. When all these diseases can evoke so much of emotional responses, you can imagine what a person will go through when they are told to have they've got cancer. Evidence shows that diagnosis of cancer evokes far greater emotional response compared to any other diagnosis. So this is where the importance of how we communicate it, what we say. Mind you, it's a very, very mind-boggling and complex task because we don't know all the answers in the first place. We don't know enough history. They're yet to undergo a lot of investigations. There's so much of dilemmas. But the patient is always worried. Where am I getting my answers from? Who is going to tell me? And in what way? This is where empathic communication in a simple manner, and this is where the clinicians have to give much more time, and the patients has to remember, and the carers has to remember that they've got a right to ask all sorts of questions to the doctor, and the clinician should be prepared to deliver it in a very empathic manner.
Excellent. And what impact does it have on the caregivers? Because we are here only talking about the patient. First of all, the distress in patient is not being addressed. What about the caregivers? We have seen that, you know, the caregivers go through tremendous stress, and nobody has the concept of respite care or anything in India that I have seen. So there is a high, rate of depression and mortality we see even in the Western world. So how concerning is that caregiver, distress?
Just before I talk about the caregivers, let me tell about the cancer patients themselves. Indian data, we haven't got many studies, but whatever studies we have got, Indian data suggests that nearly 53 to 55% of cancer patients have a mental illness. Unfortunately, this is not something which is very much sort of talked about or identified for various reasons, because the priority is to treat cancer. There are a lot of other priorities that we have, because we are still in the developing phase of various stages. So 55% of cancer patients can have mental illness. The problem is, how does this mental illness manifest in oneself, and how does it complicate in the management of that case? Many of these mental illnesses manifest in what we call as somatization. I just want to talk in Kannada for those who are Kannada patients. Sumar janake cancer diagnosis kottaga tumba bhaya agate, atanka agate, adu tumba dina continue adaga depression agbodu. Depression adaga ಅವರು ಅದನ್ನ ಹೇಳ್ಕೊಳ್ಳೋಕ್ಕೂ ಆಗೋದಿಲ್ಲ. ಭಾಳ ಜನ ಹೇಳೋದಿಲ್ಲ ನನಗೆ ಡಿಪ್ರೆಷನ್ ಇದೆ ಅಂತ. ಏಕೆಂದರೆ ಡಿಪ್ರೆಷನ್ ಅಂತ ಹೇಳಿದ್ರೆ ಏನೋ ನೀನು ಇಷ್ಟು ವೀಕ್ ಇದೆಯಾ ನಿನ್ನ ಮೈಂಡಲ್ಲಿ, ಸ್ವಲ್ಪ ಧೈರ್ಯವಾಗಿರೋಕ್ಕಾಗಲ್ವಾ ಅಂತ ಹೇಳ್ತಾರೆ. ಹೇಗೆ ಅಂತ ಹೇಳೋಕ್ಕಾಗಲ್ಲ ಅವರಿಗೆ. ಬಟ್ ಆಗೇನಾಗುತ್ತೆ, ವೆನ್ ದೆ ಸಪ್ರೆಸ್ ದೀಸ್ ಎಮೋಷನ್ಸ್, ಅದೆಲ್ಲ ಕೂಡ ಸೊಮಟೈಸೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ ನಾವು. ಬಾಡಿ ಪೇಯ್ನ್ಸ್ ಮೂಲಕ ಆಚೆ ಬರ್ಬೋದು, ನೋವು, ಸುಸ್ತಾಗೋದು. ಬಟ್ ದ ಪ್ರಾಬ್ಲಮ್ ಈಸ್ ಮೆನಿ ಆಫ್ ದಿ ಕ್ಯಾನ್ಸರ್ ಕಂಡೀಷನ್ಸ್ ದೆಮ್ಸೆಲ್ಸ್ can cause a lot of somatic problems. Cancer treatments, radiotherapy, chemotherapy can itself cause a lot of problems. If we don't explore this facet, we're in a fix. We don't know what is actually causing. We might mistakenly think that it is the cancer treatment which is causing, and then overtreat them, for example. And that can have its own implications, side effects, financial burden, etc., etc. So I'm just highlighting the importance of exploring the psychological aspects in cancer patients. So your question about cancer caregivers, we did a study in our own hospital. We looked at 145 consecutive patients, caregivers issues. So it was one of the DNB students, and I was the guide for that. What was shocking was that 75% of the caregivers had depression. And we are talking about caregivers here. So depression again manifested differently in different caregivers. Some of them was just stress factor. Many of them had to give up their jobs. 96% of them, they were actually working. Caregivers who were working, nearly half of them had to give up their jobs to look after these patients. So it's a significant factor that has to be explored again sensitively, like how we deal with the patients. So cancer management also includes caregiver management.
Well said, Dr. Divakar. I would like to have the audience, pose some questions for the panel. This is the right time. If you want to ask a question to the panelists, please go ahead and ask a question, one or two.
Thanks, sir. I just want to know what are the basic symptoms of different cancers, whatever it may be, either it is lymphoma or other cancer. What are the basic symptoms that we should know that this may cause the cancer? We should be get diagnosed for this. We should get evaluation done.
Cancer can happen in any part of the body, okay? From head to toe, it can happen anywhere. So if you find anything new, okay, like say it may be shortness of breath, okay? Persistent means it's not going away. Even after 2 or 3 weeks of treatment, it's not going away. And progressive means getting worse. Then you need to seek immediate medical attention. Don't go around shopping for doctors for 6 or 7 months and end up with a metastatic disease. So we can't name all the symptoms from head to toe. It may be headache, blurry vision when it comes to brain tumor. It may be like shortness of breath, chest pain, coughing up blood when it comes to lung cancer. It may be abdominal pain when GI malignancies. It may be like, blood in the stool when it comes to like colon cancer, or blood in the urine when it comes to bladder cancer. So anything that's new, persistent and progressive is the key. ಯಾವುದನ್ನ ಬಾಡಿಯಲ್ಲಿ ಒಂದು ಹೊಸ ಬದಲಾವಣೆ ಆದರೆ ಆ ಬದಲಾವಣೆ ಹೋಗ್ತಾ ಇಲ್ಲ ಅಂದರೆ 2-3 ವಾರ ಆದ್ರೂ ಜಾಸ್ತಿ ಆಗ್ತಾ ಇದೆ ಅಂದರೆ ನೀವು ತಜ್ಞರನ್ನು ಕಾಣಬೇಕು. ದಟ್ ಈಸ್ ದ ಮೆಸೇಜ್. ಓಕೆ, एक्सीलेंट क्वेश्चन.
हस्बैंड जस्ट 2 months ओवर वो रेडिएशन हो गया है उनका, लेकिन अभी हमें क्या प्रिकॉशन लेना चाहिए? सर्जरी, रेडिएशन, कीमो, एवरीथिंग इज ओवर नाउ, बट समटाइम्स ही इज ऑल्सो डिप्रेस, आई एम ऑल्सो.
उनको क्या कैंसर था?
हेड एंड नेक कैंसर.
Head and neck.
And
Dr.
now radiation
Moni
is completed,
and Dr.
chemo, surgery, everything is completed in Bombay. First we did the operation in Sultan Pradhan, did 2 surgery. Again third problem, again it has started within 15 days. So before chemo, after surgery, and before chemo and radiation, again problem has come within a 15 days. So again third surgery has done within 1 month. So now radiation is over 2 months. So now what precaution we have to take in life it can't grow? And any food items, anything?
Look, we Indians focus too much on the food, how we can alter it. But that is the only thing which is there in the patient caregiver's hand, and that is where the focus is there. What we have to understand, we have to take a technically correct treatment. That is the first thing to begin with. Only after that food rehabilitation and good nutritious food to make him healthy, that will come into picture. And regarding the all the precautions, whatever we tell during the radiation therapy has to be followed even after that, maybe after 3 months, because radiation is a slow process and it takes some time for patient to recover, and you have to continue those precautions during that time.
No, I am taking all the precautions whenever doctor has called, because every week, 15 days, 1 month, I am going Bombay, or Dr. Vijay Hari. Now third surgery has done by Dr. Vijay Hari in HN hospital. So now all the surgery, all the precaution I am taking, but I am a vegetarian. So what food, what nutritions I have to take, because his appetite is not so good. He is always just a chir. Sometimes no, he is so fed up ki if he is seeing me, he will tell me for food.
Vegetarians first of all should understand there are good quality protein supplements which are available. And apart from the supplements, you can take soya, you can add pulses, groundnut, all which are paneer and which are good, contains good quality proteins. You can take badam and all, because the body requires high protein diet, especially in the head neck cancers, because all this while the patient was not eating well. Okay. Apart from the proteins, it is the essential fatty acids which are very important, and people have found that they will gain weight very quickly if they are on those supplements. So that is also very important.
After surgery, he lost 16 kg weight. So always I am worried. I talked so many patients and so many doctors, so all different cases, and sometimes no, again it is repeated. So if I know, so I am very upset that time.
If I may, I'm a surgeon in the head and neck area. If I may comment on that, what you're going through is almost all the head and neck cancer patients have gone through. The person sitting 2 seats from you on the left side has gone through the same thing almost 6 years ago. So first almost 6 months is challenge, very troubling. And you heard that even the family members like you have to go through depression and so on. But on the long term, head and neck is one of the curable cancers. And look positively, you should be able to get back to near normal function. No, can't say the normal function, near normal function. But initial phase is going to be challenging.
Yeah,
frustrating.
sometimes he is complaining, here is swelling, body is not very weak. So not be afraid, we have to again go to doctor.
No, that is a normal thing. That is the part of the healing, initial treatment and the disease. We have to go through that. And then doctors like us will help you to get through. And it's a initial phase is challenging.
Because treatment I am totally positive. Because I never thought for other things. But now, little bit, I am also feeling so.
Yes, sir.
I think, sir, you should see her. I think it would be good to have a little session with her.
Yeah, so I think the key is to follow with your doctor, and make sure you follow all the advice and follow a healthy lifestyle, okay? That's the key here.
Thank you.
So Dr. Boni, coming to the next question, is there a screening test for head and neck cancer, and how do we reduce the risk of head and neck cancer?
And this head and neck cancer is one cancer which we can detect early stage. Because most of the head and neck cancer we're talking about the mouth cancer. If you just look inside the mouth, you can diagnose cancer. In fact, we did a study sometime back in about 38,000 population, and we just trained them how to look inside the mouth, what to look for, and what to do if you find something. 3 things we told them, and they picked up a large number of pre-cancer and cancer condition. One message, if you don't forget, one message I want to convey to all of you is that if there any ulcer inside the mouth which lasts more than 3 weeks, you need to see a doctor. Okay? Any ulcer which lasts in the mouth more than 3 weeks, that needs to be consulted. So most of the mouth cancer can be picked up like that. But one of the unfortunate fact is that even with this condition, most of our patients go and see about 2 or 3 medical consultations, still fail to diagnose cancer. Even ourselves need to be taught, our medical fraternity to be taught about early signs of mouth cancer.
Excellent, well said. Dr. Anthony Pius, what is the screening test for breast cancer, and how can one reduce the risk of developing breast cancer?
This can be divided into 2 categories. Patients at high risk. By high risk, I mean more than one relation having breast cancer or ovarian cancer, or the general population. Now, let's keep the high risk category separate. For the general population, every lady should go for a yearly check every year after the age of 30, and not after the age of 30. But after the age of 40, we start investigations. 30 to 40, only a proper physical examination done by a doctor. That's called a clinical breast examination. This should be done between 30 and 40. After you have crossed the age of 40, you do a mammogram once in 2 years, not every year, and a clinical breast examination every year. If you are really tensed, maybe an ultrasound would help you. It's cheap, with the absolute, a very simple test, can be done routinely. This can be repeated even every year. But for patients at high risk, you have to do these every year.
Is there a role for MRI in high-risk patients?
In high risk, yes. We do an MRI depending upon the lesion. In case you find something, then you do it more often. Otherwise, you can do it once, and then with a good quality mammogram today, you don't have to do a mammogram every year.
Ask you one question. Is there a screening test for blood cancer, Dr. Sharath?
Yeah, I mean, we really don't have a screening test in the way you put it for breast cancer and other screening procedures. But then typically what we recommend, and I think in a lot of instances it's routinely done now, you have an annual health checkup. A lot of people when they're joining a job have a screening, and thankfully there are a lot of blood tests done at that point in time. So that itself kind of default acts as an indirect screening for anything which will show an abnormality in your blood examination. We thankfully want people to pick that up early and then refer it, like what Dr. Moni mentioned, that even some of the medical fraternity need to be educated to pick up small abnormalities so that the detection is faster. But thankfully now, with a lot of people paranoid about small changes in hemoglobin and platelet count specifically, the smallest drop in the platelet count, they are running all over the place. That has helped actually pick up some of the malignancies a little faster. That's one good thing about this routine checkups which also happen.
So how worrisome should one be? Like, if you find a lump or a bump somewhere in your neck or in your armpit or anywhere in the body, how worrisome should one be, and what should they do actually if they find a lump or a bump anywhere?
Yeah, like you've already mentioned, I think if it's persisting beyond the 2-3 week interval, growing in size, not settling down, then they obviously need to have it seen by a specialist. So that's evaluated. Sometimes just a needling procedure will tell you whether it's infective or not. And most of the times, at least for a cancer diagnosis, a biopsy is always recommended. needling procedure is generally inadequate. And that is what will get recommended once you see one of the specialists in that area, depending on where the lump has actually appeared. So that's what we would kind of want to highlight and impart and tell people.
So Dr. Suchitra, apart from breast cancer screening, what other screening is available for women?
Right now there are no screening tests available for carcinoma, ovary and endometrium, but cervical cancer definitely has a screening test, what we call as a pap smear, which is done at regular intervals of 3 years. If 3 times it comes negative, it has to be continued every 3 yearly till 65 years of age. If it is combined with the HPV DNA, the newly coming DNA test,
Sure.
at least after 30 years of age, the sensitivity is increasing, so the chances of detecting a cervical cancer will be more.
So what do you do if the HPV comes back positive, but the pap cytology is negative? What do you do for those kind of patients?
When the HPV comes positive and the cytology comes negative, we just repeat the HPV DNA test after 12 months, that is 1 year, 1 year later. Still it is persistingly positive, then she is advised to go for a colposcopy.
So would you vaccinate those kind of people? Who do you vaccinate with HPV?
Ideally, vaccination is done at a very younger age group of patients. It is done at it starts at an age of 9 years and till 25 years of age. It can be given to people till 45 years of age, but how effective it will be, it is not known. So it is given in dosage of 0, 2 and 6.
So is it only given to girls, or can boys also get the vaccination?
Boys also can be vaccinated. Right now in India, if girls are vaccinated, it's more than enough, I think.
Okay. So it's very important, if you have anybody between the age group of 9 and 26, does not matter if it's a boy or a girl, or they have to get vaccinated for HPV, human papilloma virus, because it will prevent cancer, cervical cancer, cancer of cervix, oral cancer, anal cancer, penile cancer, vaginal warts, anal warts, all these things. So it's very, very, very important to vaccinate boys and girls between the ages of 19 and 26. So we would like to take a question from the audience right now.
From Kenya. Mine is a simple and direct question. I wanted to know if warming food using microwave can cause cancer.
It's a very good question. It does not cause cancer directly. The food does not cause cancer. Microwave is kind of a RF non-ionizing radiation it has got. It generates heat. Okay, so it does not turn the food into a carcinogen. But if you use a bowl that is a non-microwavable bowl to microwave it like a plastic which is not non-microwavable, then that plastic material like bisphenol and other things can get into the food and be a carcinogen. So you have to be aware what kind of a food item and what kind of a utensil that you are using. It has to be microwave safe. Make sure it is written on the bowl before you use it for microwaving. Good question. On that line, Dr. Sandeep Jain, do you think cell phones causes cancer?
There are so many studies which has happened, and all these cell towers and cell phones have been implicated. So the studies still have not concluded. So presently what we can do is to avoid using the voice mode, like you can use an earphone. That is the current recommendation as far as possible. Use more SMSs and the text WhatsApp rather than using the voice calls. So that is the doable thing which can be done. And on the legal side, people have still not concluded that the mobile towers can cause cancer. In fact, the current government is in favor of putting more mobile towers. They have approved it for the government buildings as well. So there is a controversy about that.
In India, they'll put anything. But there have been major studies. In Sweden, there was some concern for gliomas. There have been studies elsewhere as well. 22 major studies have been conducted. But when they did the meta-analysis, studied all the things, they have not found a conclusive evidence that cell phone causes brain tumor or acoustic neuroma or other cancers. But there is a probable link based on the duration of cell phone usage has been indicated, and that's why International Agency of Cancer Research has listed as a probable carcinogen cell phone. Okay, Dr. Paul, you're but don't panic, because cell phones have been there only for 2 decades. The data in these clinical trials have been looked at only for 7 years or 8 years. We don't know the long-term implications. So just don't give cell phones to your kids to play around and talk on the phones for too long, or keep near your head and sleep. We don't know. 20 years from now, it may be like, a major carcinogen. You never know. But so far, studies have not been conclusive that it causes cancer. But use hands-free mode. Be judicious. Okay, that's the message.
Difficult to do it. I think you need a case control to have association.
That's
so
what. There is no.
If 99% people are using it,
absolutely,
it's very difficult. But
it'll be an observational thing. More people coming forward.
Is needed. So in 20 years' time, we'll see the cancer rates have doubled. So then we'll say probably mobile was one of the culprits.
So the key is not to panic. Okay, but be judicious in using whatever it may be in life. Okay, electronic gadgets, not just for the cancer, but for other means as well. So we'll take a question from the audience. Please go ahead.
Good afternoon to all. I have a simple question. See, when we approach for blood donations, when we go for voluntarily donating blood, I have heard many people having a misconception that unfortunately it may end in our own blood infection, which can be one of the reasons for having blood cancer or any such. So can you clarify? Because I don't think there's anything wrong in donating blood, but I have heard many people having that misconception. It can be a problem to us by having blood infection or any such.
No.
Can that be a reason for cancer?
It's actually good for the person who donates because it kind of acts to kind of rejuvenate your cells and cell cycle. There is a risk of infectious disease getting transmitted because of a window period of our screening tests which are run in the blood bank, and thereby in spite of whatever screening is done, you may have a little window period where some infections can get missed in spite of all the testing. So that's the only risk with a blood transfusion. That's why ideally in a lot of situations we want to avoid blood transfusion first. But then when you have to give it, it's screened, tested blood which is given. There's no harm to the donor and there's no risk of any cancer being transmitted. However, if there's a history of cancer or you had treatment for cancer, then that automatically excludes you from donating blood. So any past history of a malignancy is exclusion for donation. But otherwise, a healthy person in the age group of 18 to 60 can donate blood anytime, and we would actually encourage blood donation.
Put somebody's like, a person, patients with CLL, if you take their blood and put it in a normal individual, will that individual develop CLL?
No, it doesn't happen that way because you are an immunocompetent host. Your cells will be recognized as different, and so that will automatically, get killed off. So that logic doesn't work that you've just taken some cells and put it in somebody else and it produces cancer.
Thank you for clarifying that.
Hello. ये prostate cancer क्या होता है? उसका precaution क्या लेना चाहिए और क्यों होता है? What is prostate cancer?
Yeah. प्रोस्टेट कैंसर मेन में होता है, वुमेन को प्रोस्टेट नहीं है. तो जो लोग 50 और उसके ऊपर होते हैं, people who are above 50, they are at risk for developing prostate cancer. Okay, family history is one of the risk factors. In US, African Americans are at increased risk. The race is itself a risk factor for prostate cancer. Here, aging is a risk factor for prostate cancer. Benign prostatic hypertrophy, BPH, having a big prostate in itself necessarily does not lead to developing prostate cancer. So if you have a family history, somebody with an age less than 65 developing prostate cancer, your screening needs to start at age 45. If you have somebody at age 50 with a diagnosis of prostate cancer, your screening should start at age 40, 10 years less. That's common for any cancer. So basically, it is not a disease of people in the 20s or 30s. As you get older, you will develop prostate cancer. There is no specific carcinogen that has been identified. Few have been implicated, but nothing conclusive. So any person in the general public is at risk as they get older. So you should start screening at age 50. If you are in high risk, age 45 or 40 years. And Dr. Sandeep Jain, a lot of people in the audience, maybe in Bangalore, elsewhere, everybody's interested because we see all the hoardings everywhere that the magic treatment for cancer is cyberknife. Can you tell us what cyberknife is and does it cure all kinds of cancer?
Look, cyberknife is quite like any other linear accelerator. The only difference is it is placed on our robotic arm. Okay, so it was, when it started, it was supposed to be meant for the tumors which are moving, and you are not accounting that movement during the radiation therapy. For example, if a patient is breathing and there is a tumor inside, there has to be some mechanism while giving the radiation therapy to cover that tumor appropriately. So cyberknife do that well for those particular kind of cases, but the rays which comes out is quite similar to any other rays. It's a name of a machine. It's not a name of a technique. Okay, so the other accelerators can also serve the same purpose. There are a couple of them which are available. So that we have to differentiate whether that additional benefit of CyberKnife is there in your particular case or not. Okay, so that point is very important to understand. It's not like that you can give CyberKnife to everybody and everything will become cured.
So the take-home message: CyberKnife is not a knife. Okay, it's not a sword or samurai or some cosmic, Star Wars, this lightsaber that he has, a magic thing that can chop off anything. So people have that concept. It's not a knife. It will not cure everything. It works only for small tumors. So don't take the bait that CyberKnife is the answer for everything. It's not a knife. It's just a radiation technique used for small tumors for precision administration of radiation. So that's the take-home message here. Well, thank you for participating, all the panelists. It was an excellent session, hopefully an educative session. Thank you so much.